Welcome back. You're watching Metropol Debrief. I am Terry Anchabet, standing in for Ondiro Oganga, and in studio with me we have economist Tony Watima, who is giving us his views and analysis on some of the policy and economic issues facing our country today. Now, let's look at the issue of cancer. According to the World Health Organization, cancer causes more deaths than HIV, tuberculosis and malaria combined, with 70% of the global cancer burden being low and middle income counties. Now in Kenya, cancer is now the third leading cause of death and the second among non-communicable diseases, accounting for 7% of the overall mortality rate. 37,000 new cancer cases are recorded in Kenya every year. Kenya has, in the last 3 months, lost significant individuals to this disease. Of course, we remember the late Safaricom CEO Bob Collymore, the late Kibra member of National Assembly, Ken Okoth, and the late Bomet Governor Dr. Joyce Laboso. Now, although cancer is curable when discovered early, 70 to 80% of patients diagnosed with cancer in Kenya are at advanced stages, with high incidence of misdiagnosis and inadequate screening, hindering early detection. Now, this makes cancer treatment quite costly, with 9 out of 10 Kenyans battling cancer said to be unable to afford cancer treatment, even in the public hospitals, which explains the unacceptably high annual mortality to cancer of 28,000 people. Now, according to the National Cancer Control Program and the National Cancer Institute, patients seeking basic treatment for breast cancer pay between 175,000 and 1.9 million shillings, while the cost shoots up to between 750,000 and 2.5 million when surgery is involved. Now, treating prostate cancer in Kenya costs between 138,000 and 1.2 million, while esophageal cancer costs between 126,000 to 1 million shillings. Tony, this issue of cancer, affects everybody in Kenya today. Somebody in your family, a relative, a neighbor. And I'm just wondering, from your point of view and a policy perspective, are we getting something wrong?
Yes. And the biggest number that you gave is about 70% of cases are diagnosed late. The biggest problem with that is that, and it's an indictment of our policy, that the issue is about our primary health care. You talk about developing countries able to manage cancer, it's because of a well-structured primary health care. Primary health care starts from your lifestyle, how you eat, and how good sanitation, water sanitation, how many hospitals can you access easily. You don't need to go to a referral hospital. Even in a clinic, how can you access it? And how the close proximity to it, and the level of doctors who are there, and those kind of a thing. That's the primary health care. So when you build a base of a good primary health care as a country, you are able to build a secondary where you talk about referral hospitals, which are very well furnished and all that. So the level of that is another level of investment. So the biggest problem that we miss is the primary health care itself.
What are your thoughts about how the primary health care is currently structured in Kenya today?
It's completely broken, because those are the places that you will find people will detect, especially if you're talking about the level of hospitals itself. We have the level 3 and level 2 hospitals. They will form under the primary health care itself. Those are the people who will be able to detect those early stages of cancer. Talk about lifestyle, water sanitation, all those kind of, even non-communicable diseases are easily prevented by having a good primary health care. So the biggest problem that we have, even if we are trying to fix our health policy itself, is we are not finding ourselves looking at the primary health care itself.
So government is not investing.
Even the focus itself, we look at the policy itself, they only mention about primary health care. But even investment
that's the local dispensary, the clinic.
Yes, and even the preventive side of it, that you talk about immunization and all those kind of things. I think immunization, we're doing good. Talk about water and sanitation. The issue about, like we talk about non-communicable diseases, or communicable diseases, 60% is about water and sanitation. Government has not put enough emphasis on that.
What do you think it will take, though, to get the government to wake up? I mean, numbers like this are ridiculous, to say the least.
One of them, I'm really concerned because of that, because government doesn't seem to understand that. You look at
losing 28,000 people?
Yes.
What,
You look at
annually?
the financing of the healthcare itself in Kenya. Everyone is financing secondary healthcare, not primary healthcare. Even devolved functions, the counties allocations, everyone is coming up with a level 5 referral hospitals. We need to.
I'm tempted to ask if it's the money that's driving that. Because hospitals are a very profitable business if you look at it, especially on such a secondary level.
Yes. It's also the way we appraise leaders. We appraise leaders are kind of visible and tangible projects which are big and pompous.
We can't tell the governor congratulations for opening a dispensary.
Yes, because for me, if I was to advise any county government today, focus your money on water and sanitation. You will save a lot of money on healthcare. But no one so far I've seen working on water and sanitation. Talking about sewer systems, talking about proper water access, talk about how do you manage garbage and all those kind of a thing. We have not seen even one county focusing on that. If you're able to manage even half of that, I think you'll reduce your budget of health by half. And so we have this thing that we have to build a referral hospital, a level 5 with capacity beds of 200, 1,000, but we are trying to invest in the later stages that you become sick. When you get in a serious condition is when now we can come in as an intervention from the government side. So
it's very reactionary, but not planned from the beginning. What do you think it will take for the government to begin to actually look at that? You know, sometimes they say maybe Kenyans are not angry enough. You know, we're not pushing the government to give us what we want with all these taxes that you talked about earlier.
The problem with healthcare is that it's devolved. So like all the functions is devolved. So counties tend to have different policies and approach on how you handle issues, especially within the healthcare docket themselves. So national government cannot push a policy without the intervention of county governments. I think one of the main things is if Kenyans, especially within civil society and other organizations, can work around with counties on what is the best place that you can put your money, or how do we incentivize counties to invest in primary health care? Can we inform the public what is the essence of primary health care? And then we don't appraise counties according to those pompous and big projects that are doing within the healthcare itself. And so that is the biggest problem that we have. I think there is also a need of change of mindset that primary health care needs to be understandable by many. For example, many people have an NHIF card, and the moment they get sick, they will not go to the local dispensary. They'll go to the top hospitals, which is the level 5 hospitals and all those kind of things. So the technical problem with that is that you're moving funds to the top hospitals. You're not moving it to the primary health care itself. So even as the consumer, you need to understand.
Maybe it's an issue of trust?
It's an issue of, I think it's an issue of lack of information on what exactly that you need to, because it becomes more of a misuse, and also most funds go to where they're not needed. We need to empower the primary health care, the local dispensaries. When the dispensary will want to access cash and want to pay, NHIF pays them, the more people go there, the more they can access that money, and the more they can invest.
And where does the private sector play, you know, and as far as primary health care is concerned?
Primary health, they play a very big part, because most of these dispensaries in Kenya are run by private and churches and non-governmental. And so you find most of those at that level, non-governmental, especially within churches, the Catholic Church, are the best performing because they have the investment to do that. So that's the problem that we have, that even itself, in terms of funding itself, we find that most fundings by default and sometimes deliberately moves out of the primary healthcare to the secondary healthcare when we are missing the base of it, of building a healthcare system. Even a proper healthcare system, as we talk about universal healthcare, starts by building a primary healthcare system.
Now, so you've talked about primary healthcare, secondary, and beyond that, now we're seeing a number of Kenyans going out of the country for specialized treatment. And that, of course, you know, besides the fact that we're saying they're going away for better treatment, they're taking their money out of the country. How do you see the impact of this being?
First, from the bigger perspective of it, I think we are increasing dependency levels in terms of funding our health issues. Because you look at funding today in Kenya, apart from the biggest people who fund the health issues is individuals out-of-pocket spending. Before even you talk about insurance and all those kind of a thing. Now you look at the numbers of cancer cases, the amount of money you need. Very few people can afford that. So it's people raising money for you. So those are dependency levels that moving up. And so people are moving from your cash, you're able to put some side to raise for a family friend, to raise for a family member, or somebody you know. And so that money also moves out when they're going to India getting such treatment. So it means that there is a lot of funds that are moving out, and India has structured themselves as a tourist for
medical tourism.
Medical
I
tourism.
don't like that term.
Medical tourism. And so we find ourselves that it's an indictment that we don't have proper equipments and skills that we will attract such kind of funds to remain within the country itself. So it shows a brokenness within the healthcare itself.
It's interesting though, because if you look at our neighboring countries, and not to say that the health sector is not as developed, but there's some where it's obviously not as well developed. So then Kenya becomes the medical tourist destination for our neighboring countries. And then, of course, there's a lack of faith. You know, we've talked about the misdiagnosis, if I can rope us back to the cancer issue. So, you know, how do we also build, keeping in mind that we may be the only solution for now for our neighbors? Okay.
You know, one thing, we're a solution for our neighbors, for the top elites of those neighboring countries.
Yeah, unfortunately, yes.
It's not a critical mass that we are working for. And that's where the problem, that if we're able to fix our health issues, especially working on a primary healthcare, then you build a good secondary health facilities and healthcare, we are able to attract such kind of medical tourism itself. Because I think the general, if a Kenyan cannot afford proper medication or in Kenya, I don't think a Tanzanian or a Ugandan can afford it here. So unless that middle tier healthcare system that we're able to improve, we can able to attract those kind of. But today we remain for the elites of those countries that they come to the top hospitals in Kenya, and so we'll have to restructure our health system itself. That's the biggest issue. It's a challenge, I think, that we will take time. I don't see it changing anytime soon, because it requires a little bit of time, and also building capacity of people who understand and attracting such kind of investment. It's a very expensive venture.
But we don't have time. People are, you know, people are dying left, right, and center. And I'm just looking at the, you know, in the India story, and that, you know, it's everybody across the world is going to India for treatment. From a policy perspective, what do you think Kenya can learn from the India story? Okay, the one thing that many people don't know about India has a very poor and a broken primary health care system. The same problem that we're having today is what India is. That we're trying to. Don't say that too loudly. Now our governors will be saying, you know, in India the primary isn't, but the secondary is. Yeah. For them, they focused on a secondary health care, and so build the best. Because that's where the money comes from. So they've built a very good base for that. You look at pharmaceuticals set up in India, so drugs are cheap. Facilities are cheap, especially housing and those hostels that if you're able to attend medical visits, you're able to be hosted in a very cheap place and those kind of a thing. So India itself has focused very well on the secondary healthcare and completely forgot their primary healthcare. So even Indians themselves, generally as a population, very few can afford the kind of medication and the medical facilities that they themselves provide. And so the thing we can copy about them is that how can we make maybe things like drugs cheap? How do we attract investment of pharmaceuticals cheap? But in terms of a healthcare system, it's not the right place to learn from. Yes. Well, okay. Anything else you want to add from a health policy perspective as we wind up? Okay. Or since you've been on the show, you know, before, and we're just doing a wrap up of Metropol Debrief. That's the season 1 as we prepare for the next one. Maybe some final thoughts of. Okay. One of the main things about healthcare is the issue about financing. Unless we are able to bring insurance companies, private insurance, and also government that is bringing the under the universal healthcare, the NHIF, we will not be able
to change our healthcare system. So that's one of the biggest problems. Even if government is structuring the NHIF itself today, there is a lot that goes in structuring the NHIF to meet that objective they're looking at. I don't think an insurance or an NHIF card means access to healthcare. Access to healthcare also means that there is cheaper drugs, there is good capacity of doctors and people who are able to handle those kind of cases.
So basically making healthcare affordable.
Yes, it's a bigger thing more than restructuring NHIF and the access. Yes.
Okay.
So that's one of the main things that we need to look at in terms of restructuring our whole healthcare system itself. So about what else about we talked about unemployment. I think the challenge about unemployment is that our economy is on contraction. We need to find a way that government can look at its policy, because we are in the wrong direction in terms of arresting unemployment. Today we are continuing going the same policies that is failing, and we continue going that path down. We need to look at what are the best ways to solve unemployment problems today, because we are heading in a very wrong direction.
Any magic bullets you can throw the government's way?
I don't think the problem with economics is that it takes time. You build something slowly and then you build up together, so the impact comes later. But the step is that realizing there is a problem and trying to refigure what you're doing.
Actually focusing.
Yes, so I think that's the wake-up call that we're still missing today, that we need to reconfigure our policy in terms of unemployment.
Wow, thank you, Tony, so much for your thoughts and for making time to be with us today. And now with that, we've come to the end of Metropol Debrief tonight. Thank you so much for being part of the conversation. We can keep it going online at Metropol Debrief as a hashtag. The handle is at Metropol TVKE. That's on Twitter. And remember, we are live 24/7 on Facebook and on YouTube. That's at Metropol TV Kenya. My name is Terian Chebet. Let's talk business next time.